Studi D3 Keperawatan Kampus Blitar Politeknik Kesehatan Kemenkes Malang. Demi menunjang aktivitas pendidikan dan pembelajaran, program studi D3 Keperawatan Kampus Blitar berupaya untuk menyelenggarakan program pendidikan vokasi yang sesuai dengan standar nasional pendidikan tinggi dan sistem penjaminan mutu.
Program studi D3 Keperawatan Kampus Blitar berkomitmen menjadi program studi yang berkarakter dan unggul di bidang keperawatan, kegawat daruratan dan bencana di tingkat nasional dan internasional, serta mampu menjawab kebutuhan tenaga keperawatan yang siap mengabdi ke masyarakat.
Guna menghadirkan atmosfer yang mendukung perkuliahan, program studi D3 Keperawatan Kampus Blitar menyediakan fasilitas yang memadai, mulai dari ruang kuliah yang nyaman, perpustakaan, ruang ketua prodi, ruang dosen, ruang BK, studio Philip, auditorium, gazebo, taman refleksi dan herbal, musola, serta sistem layanan peminjaman laboratorium secara online yang dapat diakses secara real-time melalui lab observation. Program studi D3 Keperawatan Kampus Blitar juga memiliki 7 ruang laboratorium kompetensi keperawatan yang dilengkapi dengan alat-alat berteknologi canggih dan sesuai tuntutan kurikulum meliputi Laboratorium Keperawatan Dasar, Laboratorium Keperawatan Maternitas, Laboratorium Keperawatan Anak, Laboratorium Keperawatan Jiwa, Laboratorium Keperawatan Komunitas Gerontik dan Keluarga, Laboratorium Keperawatan Medikal Bedah, Laboratorium Keperawatan Kegawat Daruratan dan Bencana sebagai laboratorium kegawat daruratan pasien pra-bencana hingga pasca bencana, termasuk memberi rujukan terhadap pasien darurat bencana. Laboratorium ini merupakan laboratorium unggulan dan penciri untuk mencapai visi program studi D3 Keperawatan Kampus Blitar. Selain itu, program studi D3 Keperawatan Kampus Blitar juga memiliki laboratorium kegawat daruratan dan manajemen bencana di daerah binaannya, yaitu di Kampung Candi Sewu, yang merupakan kawasan rawan bencana 3, ring 1 erupsi Gunung Kelut. Laboratorium Keperawatan Kampus Blitar memiliki pedoman pelaksanaan dan pelayanan guna memastikan kualitas pelayanan serta pelaksanaan prosedur kesehatan dan keselamatan kerja atau K3. Selain aktivitas akademik, program studi D3 Keperawatan Kampus Blitar juga mendukung kreativitas mahasiswa dalam organisasi mahasiswa guna menumbuhkan sikap kepemimpinan, kepercayaan diri, serta mengembangkan minat dan bakat mahasiswa dalam rangka melaksanakan amanat Tridharma perguruan tinggi. Selain pendidikan dan penelitian, program studi D3 Keperawatan Kampus Blitar juga melakukan kegiatan pengabdian kepada masyarakat, khususnya yang berkaitan dengan kegawat daruratan dan manajemen bencana.
Namaku Ayun, alumni Politeknik Kesehatan Kementerian Malang, Prodi Blitar tahun 2014. Sekarang kerja di Jepang udah 3 tahun. Kerja di Jepang, tepatnya di panti jompo. Kesannya kerja di Jepang gimana ya? Nano-nano lah.
Minasan, konnichiwa. Hajimemashite, watashi Yesi desu. Sari to yonde mo kamaimasen node yoroshiku onegai shimasu. Halo teman-teman yang ada di Prodi Blitar, perkenalkan nama saya Yesi. Saya alumni Poltekkes Malang Prodi Blitar lulusan tahun 2014 dan sekarang bekerja di Jepang. Saya di Jepang sebagai care worker di sebuah panti jompo yang ada di Prefektur Okayama, Jepang, memasuki tahun.
Program studi D3 Keperawatan Kampus Blitar siap mengabdi kepada masyarakat demi kemajuan bangsa Indonesia. Selamat datang di program studi D3 Keperawatan Kampus Blitar Politeknik Kesehatan Kemenkes Malang. Demi menunjang aktivitas pendidikan dan pembelajaran, program studi D3 Keperawatan Kampus Blitar berupaya untuk menyelenggarakan program pendidikan vokasi yang sesuai dengan standar nasional pendidikan tinggi dan sistem penjaminan mutu.
Program studi D3 Keperawatan Kampus Blitar berkomitmen menjadi program studi yang berkarakter dan unggul di bidang keperawatan, kegawadaruratan dan bencana di tingkat nasional dan internasional, serta mampu menjawab kebutuhan tenaga keperawatan yang siap mengabdi ke masyarakat.
Guna menghadirkan atmosfer yang mendukung perkuliahan, program studi D3 Keperawatan Kampus Blitar menyediakan fasilitas yang memadai, mulai dari ruang kuliah yang nyaman, perpustakaan, ruang ketua prodi, ruang dosen, ruang BK, studio Philip, auditorium, gazebo, taman refleksi dan herbal, musola, serta sistem layanan peminjaman laboratorium secara online yang dapat diakses secara real-time melalui lab surveillance. Program studi D3 Keperawatan Kampus Blitar juga memiliki 7 ruang laboratorium kompetensi keperawatan yang dilengkapi dengan alat-alat berteknologi canggih dan sesuai tuntutan kurikulum meliputi Laboratorium Keperawatan Dasar, Laboratorium Keperawatan Maternitas, Laboratorium Keperawatan Anak, Laboratorium Keperawatan Jiwa, Laboratorium Keperawatan Komunitas Gerontik dan Keluarga, Laboratorium Keperawatan Medikal Bedah, Laboratorium Keperawatan Kegawadaruratan dan Bencana, sebagai laboratorium kegawadaruratan pasien pra-bencana hingga pasca bencana, termasuk memberi rujukan terhadap pasien darurat bencana. Laboratorium ini merupakan laboratorium unggulan dan penciri untuk mencapai visi program studi D3 Keperawatan Kampus Blitar. Selain itu, program studi D3 Keperawatan Kampus Blitar juga memiliki laboratorium kegawadaruratan dan manajemen bencana di daerah binaannya, yaitu di Kampung Candi Sewu, yang merupakan kawasan rawan bencana 3, ring 1 erupsi Gunung Kelut. Laboratorium Keperawatan Kampus Blitar memiliki pedoman pelaksanaan dan pelayanan guna memastikan kualitas pelayanan serta pelaksanaan prosedur kesehatan dan keselamatan kerja atau K3. Selain aktivitas akademik, program studi D3 Keperawatan Kampus Blitar juga mendukung kreativitas mahasiswa dalam organisasi mahasiswa guna menumbuhkan sikap kepemimpinan, kepercayaan diri, serta mengembangkan minat dan bakat mahasiswa dalam rangka melaksanakan amanat Tridharma Perguruan Tinggi. Selain pendidikan dan penelitian, program studi D3 Keperawatan Kampus Blitar juga melakukan kegiatan pengabdian kepada masyarakat, khususnya yang berkaitan dengan kegawadaruratan dan manajemen bencana.
Namaku Ayun, alumni Politeknik Kesehatan Kementerian Malang, Prodi Blitar tahun 2014. Sekarang kerja di Jepang udah 3 tahun. Kerja di Jepang, tepatnya di panti jompo. Kesannya kerja di Jepang gimana ya? Nano-nano lah.
Minasan, konnichiwa. Hajimemashite, watashi Yesi desu. Sari to yonde mo kamaimasen node yoroshiku onegai shimasu. Halo teman-teman yang ada di Prodi Blitar, perkenalkan nama saya Yesi. Saya alumni Poltekkes Malang Prodi Blitar lulusan tahun 2014 dan sekarang bekerja di Jepang. Saya di Jepang sebagai care worker di sebuah panti jompo yang ada di Prefektur Okayama, Jepang, memasuki tahun kedua.
Program studi D3 Keperawatan Kampus Blitar siap mengabdi kepada masyarakat demi kemajuan bangsa Indonesia.
Bukan apa gue. Ini siapa ini depan bocor ini? Ada bocor.
Miss Kurota Ayun.
Yes, Miss.
How many students will attend in this meeting? Kurota Ayun? You didn't hear? Mbak Kurota Ayun sebagai MC sinyalnya harus dipastikan bagus. Kayaknya sinyalnya jelek nih. Kamu di mana?
Di ruang rapat, Bu.
Nanti ke perpus
Nah, ini
aja, Mbak.
kamu terputus-putus. Ini nggak bisa ini kayaknya kamu.
Nge-flag itu dekat dengan
Kamu
temannya.
harus
Nanti ke perpus aja sendirian.
ayo bergeser karena MC dan moderator tolong sinyalnya dipastikan bagus. Sembilan loh, sudah mau dimulai loh. Ya apa kok iki?
Apakah masih terputus-putus, nggih, Bu?
Coba cek sama coba. Coba cek lagi.
Cek, apakah masih terputus?
Enggak di tempat saya, Mbak.
Sudah lancar nggih, Miss, ini sinyal saya?
Ya, so far it's okay.
Oke, thank you, Miss Rika.
Mbak Ir juga terputus. Ini bisa dimulai dong.
Wes, dimulai. Monggo.
Dimulai Pak Agus.
Ya, monggo. MC monggo silakan.
Yes. Silahkan Mbak Kurota Ayun.
Masih mood, masih di mood.
Ini saya mulai nggih, Bu.
Ya.
Oke. Assalamualaikum warahmatullahi wabarakatuh. Shalom, Om Swastiastu,
Waalaikumsalam.
Budaya, salam kebajikan. The Honorable Head of the Nursing Diploma Study Program, Mrs. Dr. Sri Bugianti, Askep Nurse MCAP, whom we respect, our speaker this morning, Ms. Carmela Teresa de Leon, PhD RNBC CCRN, whom we respect, lecturer and fellow academia of the Nursing Diploma Study Program, and all my loving audience. First of all, let us praise to the Almighty Allah Subhanahu wa Ta'ala. Because of His blessing, we are able to come here to join this lecture of the Nursing Diploma Study Program. Secondly, may peace be upon our Prophet Muhammad Sallallahu Alaihi Wasallam, who has guided us into the right ways of life. Ladies and gentlemen, My name is Kuroto Ayun. As the Mrs. of Ceremony today, on 7 November 2022, a guest lecture of the Nursing Diplomacy Study Program with the title Mindful Practice Patient Safety Management WS Practice. We would like to extend a very warm welcome to all of you. We appreciate and thank you to all of you taking time of your schedule to join this program, participate, and share together in improving our skill. We hope this program will give an advantage for us in the future. Well, in this special morning, we have several agendas. So I, as Master of Ceremony today, I would like to outline all the agendas are as follows. The first agenda is opening. The second is listening national anthem, Indonesia Raya and Polkesmas hymn. The third is committee report of this program by Alivia Diah Elobudi. The fourth is welcome speech delivered by head of the Nursing Diplomacy Study Program, Mrs. Dr. Sri Bugianti as Nurse MCAP. The fifth is speaker's resume reading. Continue with a material delivered by our speaker, Ms. Carmela Teresa Leon, PhD RNDC, CCRN. The sixth agenda is prayer. The last agenda are documentation. Continue with closing. Well, to take the advantage of the quality time, let us open this program with basmalah together. Bismillahirrahmanirrahim. Okay, ladies and gentlemen, now let us listen the national anthem Indonesia Raya and Polkesmas hymn. So for the audience, please sit up straight. Okay, the next agenda is committee report by Alivia Dia Elobudi. So, to Alivia Dia Elobudi, time is yours.
Assalamualaikum warahmatullahi wabarakatuh. Peace for all of us. The Honorable Head of Blitar Nursing Diploma 3 Study Program, Mrs. Dr. Sri Mugyati Eskepnes MKep, we respect Mrs. Carmela Tirsa de Leon, PhD, RNPC, CCRN from Pima Medical Institute, Mesa, Arizona, as guest lecturer on this morning. We respect, ladies and gentlemen, lecturer and the academic community of Blitar Nursing Study Program, as well as to all the guest lecture participants. First of all, let us say praise to God who give thousands of favor to us on this day so that we can gather at the guest lecture Blitar Nursing Study Program held Polytechnic of Malang with the theme Mindful Practice, Patient Safety Management and EWS Practice on November 7, 2022 in Health State. I am Alivia Dialog Budi as the committee representative of the guest lecture. Would like to welcome and thanks the audience for coming to the guest lecture this morning. I also thanks all the committee and colleges who have helped in organizing this event. Let us follow this event well so that it can run smoothly and we can get the benefit. Finally, if there are any shortcomings in organizing this event, I apologize. Welcome to join this event and hopefully useful. Thank you. Wassalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh. Thank you for the report, Ms. Alivia Dia Elobudi. Before we begin our main agenda, we are pleased to have to deliver opening speech by Head of Master Blitar Mrs. Dr. Sri Bugianti, Asket Nurse MKep. Time is yours.
Thank you, Burota Ayu. Assalamualaikum warahmatullahi wabarakatuh. Suara saya bisa terdengar, Burota Ayu?
Bisa.
Bisa ya? Ya, alhamdulillah. Good morning, everyone. Good evening, Ma'am Carmila, because right now in Arizona is still on Sunday evening. Honorable to the speaker today, Ma'am Carmela Teresia de Leon from Pima Medical Institute, Mesa, Arizona. Hello, Ma'am Carmela. How are you?
Hello, ma'am. I'm doing good. Thank you.
Yeah. Nice to meet you.
Nice to meet you too.
Welcome back again to our guest lecture event. And also honorable to lecturers and staff of State Health Polytechnic of Malang dan seluruh mahasiswa yang saya cintai. Yeah. Also to all my student whom I love. The webinar today is to support the patient safety management and EWS practice with the topic is mindful practice. This topic is one of crucial thing of nurse student here. I am very happy and grateful for this guest lecture today. For all my students, you are the future nurse. So the guest lecture today is very important for you. And we have Ma'am Carmela as the expert to deliver the material about mindful practice. So please be attention to the guest lecture. And I want to say thank you, Ma'am Carmela, for your time to share your knowledge and experience with us.
It is such an honor for us. We are welcome you to come and visit Blitar in the future. Yeah. And last but not least, by saying Bismillahirrahmanirrahim, this event is start. Well, thank you for attention. Good morning and see you. Ya. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam.
Waalaikumsalam.
Thank you for the opening speech to Mrs. Dr. Sri Bugiandi as Nurse MCAP. The announcement for participants, the attendance form is available in room chat, Zoom, and YouTube. So for the participants, please fill the form. The announcement for participants, the attendance form is available in room chat, Zoom, and YouTube. So for the participants, please fill the form. Ladies and gentlemen, the next agenda is reading speakers resume. Continue with our main agenda, guest lecture of the Nursing Diploma Study Program with the title Mindful Practice, Patient Safety Management, and IWS Practice, delivery by Ms. Carmela Teresa de Leon, PhD, RNBC, CCRN. For this agenda, I hope the audience will take notice from the beginning of the material to the end. And the session moderated by Elnona Humaima as moderator, I invite you to take over this session.
Thank you, MC. Assalamualaikum warahmatullahi wabarakatuh. Good morning and good evening for Dr. Carmela because it's night time in Arizona. Ladies and gentlemen, my name is Elnona Humaima Iza as the moderator of today's occasion. I'm very happy to see you here and welcome all of you to guest lecture of Diploma Study Program with the title Mindful Practice, Patient Safety Management, and EWS Practice. Our speaker today is Ms. Carmela Teresa de Leon, PhD, RNBC, CCRN. And let me read the CV from Ms. Carmela. The latest educations from St. Paul University, Philippines Graduate School, Doctor of Philosophy in Nursing Science 2019, dissertations, attritions to completions, progressions theory in an associate degree nursing program, honors, dissertations passed with distinction. University of Santo Tomas Graduate School, Master of Arts in Nursing, thesis, process of verbal abuse among female Filipino nurses 2002 with honors, summa cum laude. University of Santo Tomas College of Nursing, Bachelor of Science in Nursing to 1998 with honors magna cum laude. Next. Awards and certifications. Mentoring Excellence Award, Arizona Nurses Association 2013 until 2014. Outstanding Educator Award, Student Nurses Association of Arizona 2012 until 2013. American Association of Critical Care Nurses, AACN, CCRN, Adult Certified Current. American Nurses Credentialing Center, ANCC, Adult Medical Surgical Nursing Certified, RNBC, Current. Next. Teaching experience, Bima Medical Institute Department of Nursing, Senior Faculty Member, 2006 to present, Didactic and Simulation Laboratory Faculty for ADN students. University of Santo Tomas College of Nursing, Nursing Clinical Instructor, Didactic and Clinical Faculty for Community and Medical Surgical Nursing Courses, 2002 until 2005. Next. Related experience, Banner Gateway, Banner MD Anderson's Cancer Center, ICU Oncology RN, 2007 until 2020, critical care services for adult bone marrow stem cells transplant patients. Banner Mesa Medical Center Medical Surgical Nurse 2005 until 2007, Orthopedic and Bariatric Specialty Services. Manila Health Department 1999 until 2002, Public Health Nurse. Next. Publications and papers, attritions to completions, progression theory in an associate nursing degree program, Journal of Nursing Education and Practice 2020. Navigating the Storm, Integrative Review of Attritions 2018, a Nurse Query, Journal of Arts and Aesthetic and Nursing and Health Science 2017. The memberships, next. American Nurses Associations, ANA, Arizona Nurses Association, AZNA, American Association of Critical Care Nurses, AACN, American Nurses Credentialing Center, ANCC, Sigma Theta Tau International. Such an amazing achievement. Now, allow me to welcome the speaker, Ms. Carmela Teresa de Leon, PhD, RNBC, CCRN, to deliver her presentation. Hello, Dr. Carmela.
Hi, good morning. Thank you, Ms. Elnona, for that very comprehensive introduction. I would just like to check, can you guys hear me well?
Yeah, we can hear you well.
Thank you. And thank you also to the welcoming remarks by Dr. Sri Mujanti, to the administration and organizers of this learning event. It is an honor for me to speak with all of you and hopefully learn with all of you in all the discussions that we're going to have today. So to make use of our time wisely, let us proceed with the presentation. Would you like me to share, or are you going to be the one to share my slides?
Sure, ma'am, you can share your slides.
Okay, and that's the updated version that you got.
I'm sorry, what?
Is it the updated version that we got?
You can share your slides or we share your slides.
I'll just share it. That way it has the update.
Okay, you can start now, ma'am.
Okay. So our topic for today is mindful practice, patient safety, and EWS practice. So it is very essential in our world today to obviously keep our patients safe. Just like most of you, all of us all over the world are certified through our local boards. So I'm sure Indonesia has their own board of nursing, just like how the Philippines and the US and all other countries has a board of nursing to regulate our practice. Obviously, that is to make sure that we are providing safe and high quality patient care. So our goals for today is obviously to be mindful of our practice, because sometimes, things become a routine for us. And when things become a routine, sometimes we don't pay attention to what we are doing. And that's when errors occur and unfortunately injuries occur to patients. So let us pursue our objectives for today. At the end of the presentation, each of you should be able to name 3 international patient safety goals of 2022. So every year, patient safety goals are released by the Joint Commission. And we'll talk about who the Joint Commission is in a little bit. Number 2, identify at least 3 areas of practice that you can apply in your own work to modify your workplace. So obviously, there are certain things you cannot change, but hopefully you could pick up at least 3 things you could immediately apply in your work settings. And number 3, discuss the steps to follow in incident reporting in the workplace. And I think this is an international standard that we all follow, that when an injury happens, it is very important for us to figure out the source or the cause of the incident, so that we could avoid doing it again in the future. So those are our 3 short objectives, and hopefully we could learn through them with our presentation today. So like I said, mindful practice involves no shortcuts. the goal of mindful practice is to always think of safety. And our goal is not to cure or to remedy. Our goal is to actually to prevent, protect, and preserve. Because truly the saying is true that an ounce of prevention is better than a pound of cure. So our goal today is to go over the National Patient Safety Goals. So the National Patient Safety Goals, or otherwise known as your NPSAG, are the list of goals that are annually released by the Joint Commission that are generally followed by most of the hospitals here in the United States. And not only the hospitals here in the United States, but other countries that access the Joint Commission for their accreditation have to follow the National Patient Safety Goals. And each hospital is graded, just like a report card on how they are meeting those national patient safety goals. The national patient safety goals changes every year. It depends on the statistics of the things that are happening in the clinical setting. So for today, we're actually just going to discuss the 7 out of many national patient safety goals, because there are many variants of the national patient safety goals. Sometimes there's a list specifically for acute care setting. There's a list for your ambulatory care, or otherwise known as outpatient. And obviously, there are also a list of national patient safety goals in the community setting. So I combined all of them and chose the 7 top national patient safety goals that applies to majority of these settings. That way, depending on where you are practicing in Indonesia, you could probably identify with a majority of these common sources of injuries among our patients. So obviously, before we start with the 7 national patient safety goals, who are the Joint Commission? Who are these people? So essentially, the Joint Commission is a non-profit organization that has been established 70 years ago, and they work with multiple global institutions as the driver of quality and improvement among patient care. So they are a group of people that, based on the research and outcomes of multiple critical care hospitals, community hospitals, ambulatory hospitals, they are the ones that set the standards and accredit these facilities in order for them to improve the healthcare for the public that they serve. So what would happen if you are not accredited? Normally, the accreditation is tied with insurance payouts, and this is both for private and public hospitals. So when you get the Joint Commission seal, the one you would see on the right side of my screen, that is a good seal to have for any organization, so that your organization is labeled among the ones that has passed the accreditation and safety standards. That means that we provide one of the best and safest service among the people. So the Joint Commission usually does surprise rounds aside from their scheduled rounds in the hospital and other ambulatory care services, to make sure that we are keeping to the standards, regardless if it is our time to be accredited or not. So when I refer to the Joint Commission, that is what I'm referring to. This is the organization that accredits the hospitals based on the national patient safety goals. So let's start with our very first and most important patient safety goal. This is one of the safety goals that has been on the list for quite some time now. And year after year, we still hear incidences of injuries that occurs related to not following this safety goal. So the number 1 safety goal is to improve the accuracy of patient identification. So I am sure, just like in Indonesia and in the rest of the world, there were instances where we have given the wrong drug to the wrong patient, where a patient received the surgery that was not meant for them, or worst case scenario, we discharged a patient that was not supposed to be discharged, because let's face it, some patients have the same or similar sounding name or similar initials. So therefore, with technology, and even if you don't have electronic charting, it is mandatory for every healthcare worker, not only nurses, but it includes physicians, surgeons, phlebotomists, radiologic technologists, or physical therapists, the first thing that they do after washing their hands, coming into the patient's room, is to look at the patient's armband and verify the patient's full name, the patient's date of birth, and or the patient's medical record number, or what we call our MR number. And that is the numbers you would see in the screen, the date of birth or DOB, the medical record number or social security number, and obviously the patient's name. It is ideal that if the patient is alert and oriented, that they actually verbalize it themselves. But if the patient is a pediatric patient or is unconscious for some reason, or is intubated and sedated, it is mandatory that before we do anything, that we actually verify the patient's name and date of birth or MR number. And this has caught many accidents from happening, or many incidents from occurring. With technology, starting in 2005, and with the use of technology, most hospitals have instituted what we call your positive patient ID. So what does positive patient ID mean? Or when you hear it in the clinical area, we call it our PPID. So the PPID is when we have a scanner connected to our charting, to our computer charting, it actually scan the patient's armband. So the armband may either have a barcode similar to the one here at the base of the name band, or a QR code that it would respond to. So this is very important prior to giving medications. So that is mandatory, because once you scan the patient's armband, it would actually upload the patient's current medications. And or if you're going for surgery or anesthesia, or even using materials for the patient, if you're using a catheter versus cleaning supplies for a wound, it actually does not only help us clinically to identify the patient and prevent errors, but this positive patient identification scanner actually helps our financial side of the hospital to actually charge as the patient consumes this medication, consumes this supply, and also undergoes certain procedures. So that is very important. So for those hospitals who are not yet electronic, it is mandatory that you have a printed copy of their medical record or medication administration record, or if it was a surgery, you have the surgical consent in front of you, and you'll still check their name and date of birth. And let's be honest, sometimes healthcare workers at the bedside, nurses primarily, sometimes you get so busy and that you forgo that very important step because you're saying, oh, I know my patient. But let's face it, there are circumstances that you get so busy, or there are patients with similar sounding names, or worst case scenario, the patient move rooms, because sometimes when we have traumas coming in, we have to move patients to another room, and then you just assumed it's the same patient. There you go. There's an error that occurred. So positive patient identification is very important. So therefore, what are those programs that our hospitals have instituted to prevent nurses from making a shortcut? Even if they already have scanners, or if they don't have scanners, they have to check it with a paper chart. So we came up with a program called I Did, ID. So it was a sticker. Now, when I was a new nurse in Arizona 16 years ago, and I came practicing from the Philippines, we had these stickers all over our hospital. So you'll see it posted on the door. You'll see it posted in the medication room. You'll see it posted even by the bathroom of the patient. And then as a new nurse, I asked myself, what are those stickers for? ID, right? So ID in the world is shortcut for identification, but the slogan sticker actually stood for I did identify my patient. So it was a very good reminder for all of us healthcare workers, especially nurses, not to skip that step, that very crucial step of really identifying the patient, no matter how busy or not so busy you are, because that is one of the first steps to stop an injury or incident from happening. So very, very important. So that's very simple. You could just identify your patient by putting stickers around the facility to remind patients that their nurses should actually be asking for their name and date of birth. I know we had patients, they're tired, they're sick. Sometimes they'll complain, why are you asking my name again? You just met me 5 minutes ago or 20 minutes ago. But it is very important to emphasize to our patients the culture of safety. And normally I would point out to the sticker, I understand I met you a few minutes ago, but it is very important for me to keep you safe. And that is my common dialogue with my patients, and eventually they'll get used to it and they'll actually ask other nurses who did not ask for their name. And that is a good reminder where safety comes from the patient, because it always has to come from the person that is receiving the care. So that is patient safety goal number 1. And that is just basic, identifying the patient. So what are the other injuries or occurrences why the Joint Commission actually made this one of their national patient safety goal? So one very important reason, not only asking the patient about their name when you're doing something with them or administering a medication, one important component of identifying the patient is when we send specimens. You see how important specimens are, because sometimes there's that name tag that you attach to the vial of blood or the specimen you got from the OR. The only link that connects the patient to that specimen is that identification sticker that you applied to that tube or that container. So I'll give you an actual example that happened in one of the places I worked with. So I worked on the oncology floor a couple years back, and you know how dangerous chemotherapy medications are in cancer treatment. So we've had a patient, so most of our patients, laboratory-wise, you know, when you pull up the results, if they're all leukemias, their labs look very, very similar, correct? But unfortunately, what if one patient is getting treatment and the other patient is just starting their treatment? So long story short, I had a nurse who took blood samples from one of the patients that I was telling you about, and she also took blood samples from another patient. The rule of thumb is in blood draws or any specimen collection, you never go out of the room without labeling the blood product or the blood specimen. So long story short, the nurse did not follow this simple rule of identifying the patient, tagging and labeling the specimen correctly, putting it in a separate specimen bag, and tubing it down to the laboratory. So what happened in that scenario where wrong labeling happened? So one patient who just finished the treatment actually had a remission of her cancer, right? So that's good news, because that means we don't need to give more chemotherapy. And this other patient is just starting treatment. So it's confirming to us that, okay, this is in your treatment, we're gonna continue with your treatment. Long story short, imagine those two specimens switched. So what happened? The person who needed the treatment is not getting it because it shows in their labs that they were cured or in remission. And the other patient whose lab draws were mislabeled was gonna get treatment when they don't need it anymore. And that treatment is not only expensive, but also very, very dangerous. So what happened? Thank God, you know, there were, you know, shift to shift nurses. You remember, and the doctors also reviewed, you know, their charts. Thank God we found out immediately, oh, there's something wrong. And imagine the emotional upset the patient had to go through when she heard she still had cancer, where the other one heard she was cured, like a miracle, when in truth, she actually needed the treatment. And that is just plainly because no one labeled it correctly. So it doesn't stop to identifying the patient. You must make sure that the label you are attaching on any specimen is correct. And that is one of the worst errors related to not identifying the patient correctly. So this is very important, right? Very classic. Patient's name, their date of birth, MR number, and very important, who collected. Unfortunately, that nurse had to go through remediation and had to be let go. And I'm not sure if she had to be reported to the board. But obviously, those are legal things that happen to the nurse. Imagine her sense of self and her trust in herself. Thank God, no direct injury happened to the patient, but it could be worse, right? And obviously, I'm sure the nurse learned. So what did we do after that big incident? This was around 2015 when this happened. So what did we do? We instituted another special project under that national patient safety goal of identifying patients, not only patients, but any specimen coming from the patients. So we had a new program, new stickers were added to our ID. They put out the red rule. So what is the red rule? Why did we call it the red rule? Because it was a rule that had to be followed by everyone. And why did we mark it or called it red? Because, just like in the stoplight, red, stop, or you could kill someone, right? So that's international all over the world. So we followed with the red rule program. So what does the red rule mean? So the red rule entails that now, not only do we ask the patient their name and date of birth or MR number, and we verify on the sticker and the same sticker that we attach to any specimen, this time there's an extra step with the red rule because we had to self-report that something happened, and the Joint Commission and all the accrediting bodies agreed we had to do something to re-educate not only that nurse, but every nurse that is working in our hospital. So with the red rule, if the patient is alert and oriented, the patient actually had to initial the sticker himself and review, this is my name, this is me, and this is the correct specimen. If the patient is, unconscious, sedated, or very, very sick, we need to get a second person to sign the sticker before we attach it on the specimen, together with obviously our Lawson number, which is the number for every nurse that is unique, the time of draw, and the date of the draw. So those are the additional things that we had to do because something happened, right? A sentinel event happened. So that is a classic example now that not only our hospitals, but other hospitals are following after that sentinel event of that switched specimen, which is basically under correct patient identification. So now if you hear the red rule, that is what the red rule means. So we're done with identifying the patient. What is the second identified problem area for patient safety? So the Joint Commission identified that effective communication between healthcare workers, especially about information and data that is pertaining to and could provide better care for the patient to prevent delay of care. So what happened now, and this is not just per hospital, this is all over the United States and most accredited hospital by the Joint Commission, they are required in their policy and procedure to indicate that when a critical lab is resulted from the laboratory, we don't just wait for it to be posted, if it was faxed, if you are still on paper charting, or in the case of most of our hospitals, we've been on electronic charting since 2005. What if the nurse was busy and you never looked at your charting because you were doing something? So now the laboratory people are required according to this national patient safety goal. So for example, let's pick a very simple critical lab. So let's say potassium. Isn't it potassium is 3.5 to 5 milliequivalents per liter. And potassium is a benign electrolyte, yet if you have too much of it or too little of it, one of the most common problem is cardiac arrhythmias, right? You could even code if you have too little or too much of potassium. So let's use that very simple example. So now the lab, regardless of what critical lab they're calling about, they could be calling about potassium, they could be calling about critical platelets, they could be calling about critical hemoglobin. So on the oncology floor, that's very important because our patient could be bleeding to death with chemotherapy. So they actually have to call us. So the time frame is, once it's resulted from their machines in the lab, they need to call the floor and talk to the nurse taking care of that patient within 15 minutes of getting that result. So that's the first step. So they would actually call the nurse, look for the nurse, report the critical lab to the nurse. and they, the lab people, see the connection of all the healthcare workers. They have to document who they talk to, so that would be the RN, and what did they report. So that needs to be documented on their side. For example, they called at 7 a.m. They have until 7:15 to find the nurse, the direct carer of the patient. Next, so the chain of command is now on the nurse. The nurse, depending on, do I have standing orders to replace the potassium, or do I don't have standing orders? And most of the time, depending on your unit, we already have standing orders. But if you don't, then you have 15 minutes again to call the physician. So that's your second critical communication. So from 7 to 7:15, the lab to the nurse. From 7:15 or whenever she got the call, she has 15 minutes to call the physician. And obviously the physician, once you get a handle of the physician, you need to give us your S-bar. And everybody is familiar with S-bar, right? Your situation, your background, your assessment, and your recommendation. Very short. So you tell them, this is patient X, my current potassium is like this. These are my no other symptoms right now. Would you like to order a potassium replacement? And the doctor would either give the order or not. And obviously, again, as the nurse, you need to document who you talked to, what you reported. And this time, you need to document what orders you got, or in some cases, if you did not get orders. That way you are covered, right? Then they may have reasons why you can't get the order. So that is the third component, the timeliness of reporting. So the time frame is usually very similar among hospitals. 15 minutes is a very reasonable time from communication to the last communication. So that is patient safety goal number 2, improve the effectiveness of communication among caregivers, especially among critical results. So what are other examples of critical results I've received in the past, aside from your general labs? I've received critical results from radiology, where the radiologist would actually call the nurse on the floor saying, your patient has a big clot, make sure you call the surgeon because we need to go to emergency embolectomy, or your patient has this critical bowel obstruction or aneurysm, you need to immediately go to surgery. So those are examples of critical labs and test results. So that includes imaging, so CT scans, ultrasounds, and MRIs. Obviously, very, very critical, where we actually need to call in the surgeon, especially in the ICU. So if no one actually called and we were just relying on the charts to be opened by someone, obviously someone could die, right? And delay of care could happen. So take note of patient safety goal number 2, improve the effectiveness of communication among healthcare workers. So next one, so we're now down to the third one. We're almost halfway there. Another cause of injury and safety issue in the healthcare system is the safety of using medications, right? I'm sure you'll agree with me that about 70% of our task on a day-to-day after your other interventions, nursing assessment, nursing admissions, and nursing care, a majority of it includes administering medications. And we all know that medications, depending if you give it to the right person, with the right dose, with the right route, with the right frequency, that it could cause harm, right? So therefore, very important to our student nurses, you are all nurses in training, or even to our veteran nurses, to help them be reminded of how important that simple task of preparing and administering meds are. So we even have annual conferences here just to remind nurses, even if they've been practicing for 20 or 30 years like me, to go back to the basics and be mindful of what you're doing. Because if you've been doing it for 20, 25 years, sometimes you're like a robot. You're doing it without thinking, and that is when injury happens. So according to the Joint Commission, how could we improve safety? So we could improve safety by number 1, only prepare one medication per patient at a time. I know if there are other nurses here listening in our seminar, if you are working in an outpatient long-term care facility where your patient ratio is 1:20 or 1:25, which I do not agree, but I know it happens everywhere in the world. I know when I was a nursing student, we used to have a tray with little cups, like a waitress, where you have medicine cards and you're preparing everybody's medication like a factory. Obviously, that practice is not recommended anymore, right? Multitasking is not recommended anymore because we realize multitasking leads to errors. So the recommended is one patient at a time. So one patient at a time, and you need to label it. So here in front of you is an example of patient labels. Depending on your pharmacy or your institutions, our pharmacy usually prints the patient label. Why? Because remember I told you from patient safety goal number 1, even our medication administration, you need to scan. So that's why you need to have a barcode with your medication. Every medication that you prepare, there's obviously the machine or what we call our Pyxis, where we lock all our medication. I'm sure in some countries, even when I was training as a nurse, we had medicine cabinets. So not anymore. So we have actually electronic, just like a little robot. It would dispense your medication with your labels. So different hospitals have different products or Pixie system that dispense their medication, or it could be old school. Your pharmacy sends it to you labeled. So we always remind our new nurses, our student nurses, and even our veteran nurses to always do your 3 checks. So what are those 3 checks? I call it my 3 Ps. 1, when you're pulling the medication from the container or from the Pyxis. 2, when you're actually preparing the medication, if it is a vial, you're aspirating it, or if it's a pill, you're cutting it. That's the second P, preparing the med. And the third check actually happens at the bedside. When you're comparing your MAR, your medication administration record, with the patient, similar to patient goal number 1, right? Ask the patient, what's your name, date of birth, and this is the medication I'm giving you. So the piece happens in the med room. The third P happens in the patient's room. So we remind nurses, don't be like a robot. Don't go in. Be mindful of what you're doing. So be mindful, read and document and double check, is this the right med, the right route, the right dose, the right frequency, the right time, right? When you're pulling, when you're preparing, and when you are providing it to the patient. So those are your 3 checks. I'm sure our nursing students, when you get checked off in medication administration, right, we sound like broken records to you. But it's okay to sound like a broken record because you don't want to be hurting someone, right? Imagine if that was yourself or your family. And that's always my goal. How would I want myself and my family to be treated? So that's the 3 checks. And then, of course, we use technology to help us. So this is an example of a safe label system. Most facilities have at least one in the facility, if it's in the pharmacy, or if your facility is big and has lots of funding, then you get one for every medication room. So if you look at the image, the best one I could find for you, after it scans, it actually reads it for you. There's a speaker that actually reads what's the drug, how much in milligrams, and how much in volume. And then here at the bottom, it actually prints out a sticker, especially if you're attaching it to a syringe with the barcode or the QR code. And that is true for all medications. You just need to scan it and then it'll print out a sticker. What if your hospital does not have all this technology? Because let's face it, technology is very expensive. So we go back to old school, and this is not new for us nurses, right? Even for nurses as old as me, that's been doing nursing for 25 years. So we have our old school label. So we have stickers, pre-printed stickers of all or a majority of our drugs. If it is not pre-printed, so here we have the most common ones we use, labetalol, your ephedrine, your phenylephrine, your atropine. What if you don't have these pre-printed ones? You could write your own. And if you notice, the stickers are very bright. They're either bright yellow, bright green, or in some cases, if the drug is really dangerous, it's in red. So you actually need to write the drug name, the strength of what you added, and then you attach it to the IV if you included it in the IV bag. It even, for unstable drugs, you even need to write when you prepared it because it could be expired or unstable or not. It's expired already in terms of it's past the time that is safe to give it after you reconstitute it. Do you have a question? Okay, so these are examples
Sorry,
of.
ma'am.
So if you don't have the electronic labeling, you could use. So in continuation, for me, I work in the ICU, especially, I'm sure you could all remember during COVID or even before COVID. In the ICU, sometimes you need to give more than 5 drugs at a time. So another component of safe medication administration is labeling your meds and your lines or drips. And why is that? Very obvious, right? For compatibility of your site. What if the drug is not compatible to the other drug that you're infusing? So we need to make sure that you label your lines, you label your ports, and most importantly, you know what each drug is when it is attached to the IV pumps. That way you know which one is safe to push something versus, oh, this drug is not compatible with another drug. And that's how organized nurses are, right? It takes a very strong person to organize such a busy patient, right? That's why in the ICU, we only get 1:1 or 1:2 patient ratio because they are so sick. And even if they are so busy, an organized nurse labels her lines and her meds would avoid patient injury. So this is what it looks like. So see how it's labeled there. If I'm running an insulin drip, if I'm running my pain medication, my fentanyl, and then if my free line or what I call my med line where I could push other drugs in between. And obviously see how it is also labeled on the connection ports if certain medications can be Y-lined together or piggyback together because sometimes we only have 3 lines from your central line. So that's how busy some patients get, right? When they're very sick with sepsis or with ARDS, your acute respiratory distress. So that's technically not new. We have done this for years and years, but under the National Patient Safety Goal, it is under the criteria of safe medication administration. So again, this is old school. You know, remember when we were nursing students 25 years ago, we would label our medicine caps. Obviously, you don't leave your needle like this, but it was the best picture I could find for you. So you need to label. You could do manual stickers if you don't have the computer to print out the stickers for you. And then, of course, in addition to patient safe medication safety, there are certain drugs, especially your anticoagulants. Remember your heparin, when you have blood clots, when you have a heart attack, when you have a stroke. Another criteria for patient safety goal number 3, you actually have to have a second nurse verify your drug before you give it, before you start they need to watch you attach the drug, the pump before you hit start. A second nurse needs to visually check what you entered, what you're hanging. And this is very common in the ICU. We call this your independent second nurse verification. And they have to chart independently that I saw X drug given by X nurse at X time, how much, and it's a whole charting. And then obviously, what's another medication issue that the Joint Commission found out? They also found out that continuity of home medication to the inpatient and then from inpatient to discharge back to home also contains errors where certain meds were forgotten to be reordered, or worst case scenario, some medications that has supposed to be been continued to discharge were not ordered. So on admission, the nurses or the nurse who admitted the patient and the physician who admitted the patient, they need to verify all the home meds. Make sure that they only order what the patient needs inpatient, and sometimes you have to stop certain medications inpatient. And then on discharge, that you make sure that the patient's primary care provider, you know, the doctor outside the hospital, has a copy of that medication because things, sometimes medications fall through the cracks and they forget, especially if your patient has 10 or more meds and they are elderly and cannot remember. So according to the Joint Commission, those pre-hospital, inpatient, and outpatient, again, needs to be talking, and there should be a printed copy of the meds. So that's under patient safety goal number 3. Okay, so we're now halfway through. So we have patient safety goal number 4, reduce patient harm associated with clinical alarms. And this is where we are going to be discussing the early warning system, or the EWS. So obviously through the years, with the advent of technology, with the advent of monitors and all these machines that are helping us in clinical, unfortunately, they all have alarms. And alarms are good and bad in a way. Good because it tells us that something is wrong, right? It tells us that there is something we need to check with our patient. But the bad thing is, not only for the patients, but also for the nurses and other healthcare workers, we have now what we call the phenomenon of alarm fatigue. If you keep on hearing something frequently, it becomes, your mind becomes adapted. So there would come a time you'll just ignore the alarms. So that is what we call alarm fatigue. I don't know about you, but working in the ICU for almost a decade, sometimes I go home and I wake up in the middle of the night hearing alarms, thinking, oh my gosh, did I turn off my alarm? Only to realize, no, I'm at home sleeping. That's how bad those alarms could get, even when you are off. So obviously, what did the Joint Commission recommend with regards to alarm fatigue so we could avoid it? Number 1, we need to be reviewing our alarm parameters. So each patient is different. Therefore, you should calibrate your alarms based on their baseline, not based on what's normal for everybody. Because if you calibrate it based on each patient's parameters, blood pressure, heart rate, respiratory rate, then they wouldn't alarm if it is based on what is normal for each patient. So that is 1. Number 2, we try to lower the volume of each alarm. I worked at night when I was a bedside nurse in the ICU. So we don't put our alarms too loud that it could wake up the other patients. So instead of sitting in the nurse's station, we would be sitting near our station hub. So if I had 2 patients, I'll be sitting in the middle of the 2 rooms with my computer. So I could lower my alarms just enough for me to hear it and not the rest of the unit. That way you minimize alarm volume, and after you adjusted your parameters. The third thing that the Joint Commission recommended to prevent alarm fatigue on the part of the nurse is to never turn off an alarm until you've figured out why the alarm is alarming. Right? You get into the room, you look at your monitor, you look at your patient first, right? Okay, why is my thing alarming? Always check the patient. Once you've made sure that the patient is actually safe, that it was just a technical error, probably the lead came off, that's the only time you turn off your alarm. Because sometimes when you have alarm fatigue, your tendency is just to mute and then walk away. Oh, this alarmed earlier. What if this time it's the true alarm? Just like the boy who cried wolf. So you never turn off an alarm unless you verify that your patient is safe. So how about the patients? Remember, if the nurses are getting alarm fatigue, imagine the patients who needed to rest. So what did we do? Again, we calibrated their alarms based on their own parameters. Number 2, we lowered the volumes. Number 3, we actually offered earplugs to patients so that even if their alarm was alarming, they are not hearing the alarm so much. And remember, the alarms are not only auditory, the alarms are also visual. They're flashing lights. So for some patient that disturbs their sleep, so what do? We turn the alarm monitor towards the nurse. There's a window towards the hallway. And sometimes even the IV pumps, we cover with a towel so that the light does not disturb the patient. And we give them eye covers also. So those are the things we did to minimize alarm fatigue on the part of the patient. So almost the same as the nurse, we just added earplugs. and eye covers if they want to, and obviously turn the monitors away from the patient so that the light does not disturb them. So that is patient safety. Goal number 4, minimizing fatigue from alarms. So now we'll discuss another alarm, which is one of the main things that the organizers requested from me. So we have what we call the early warning score. So the original was just EWS. So it's called early warning score, or EWS. And now the most modified one is the Wellington early warning score, or what we call WUS, right? Or WUS. So what's the history of the early warning score? The early warning score actually started in around late 90s, 1997, where multiple hospitals in the United Kingdom did a study on multiple ICU patients, that they found out that several hours before a patient died, they already had subtle data that was telling us that something bad was going to happen. So that's why the tool was named early warning score, because we could already determine by 6 data. So what are those 6 data? The majority of the data is actually your vital sign, right? So we have your temperature, you have your heart rate, you have your respiratory rate, you have your blood pressure, then you have your O2 saturation, that's already 5. And what is the 6 criteria? Their level of consciousness. Remember, you have your Glasgow Coma Scale if you use that. Or in the case of trauma patient, we just use AVPU. So AVPU stands for alert, verbally responsive, only responsive to pain, or unconscious. So that's your AVPU. So in front of you, this is the most modified one. So this was developed in Florida around 2011. So imagine, from 1997, it took them almost a decade and a half to actually came about with the study and the tool. So the most current tool you have, some countries call it your new early warning score. Then for the pediatrics, we call it PEW, pediatric early warning score. And then this one I'm showing you is your Wellington early warning score. So basically, what was the Wellington early warning score? So this was around 2011 when they modified it from the initial EWS. I started using the early warning score probably around 2011, 2012 also here in the United States. So what is the early warning score? So the early warning score is usually done in the ED, so upon admission, or in the med-surg floor, right? That's your basic floor, or in your progressive care unit, or PCU, or otherwise known as telemetry, a little higher level where the patients are on heart monitor. So those are the 3 units where we use early warning score. With electronic charting, it was very easy for us because the computer actually collects all the data per patient. And then if it meets the criteria, so, our IT, you could just program it, it would already trigger if the respiration is going too high or too low, the O2 sat is going too high or too low, the temperature, the systolic BP, and the heart rate. So essentially, the nurse needs to just monitor their chart at least every 2 hours. And this is one of our silent alarms. Why is it silent? Because there's no alarm ringing. It actually is just a task on our charting that tells us, oh, something is wrong with your patient. The early warning score is a total of 20 points. So where does the 20 point come in? It's the 6 criteria with the highest score of 3, so that's 18, right? And where does the other 2 points come from? If the patient is on oxygen or not. So if they are not on oxygen, your highest score is 18. But if the patient is on oxygen, the highest score is 20. So what's the simplest way I could explain it? The higher the score, the more critical your patient is becoming, the sicker that they are becoming. And then the lower the score, our gold score, average score is 0. That means they are within baseline, right? So it's color-coded, yellow, orange, and red. And obviously, MET or blue is medical emergency team. So some hospitals call that your code blue. Hence, that column is colored blue. Okay, so you don't need to memorize this, by the way, because this is provided in your charting. It's provided with posters in your station. So you just need to pay attention. So in our hospital, there's actually a nurse called your SWAT nurse, or in your patients with acute condition, there's a special nurse whose job is only to look at all the in the whole hospital for every shift. I used to be one of those nurses. I would be a SWAT nurse, and I would just go to codes, I would go to rapid responses, or every hour I have an Excel spreadsheet where the computer sends me data. Okay, this patient in this floor has an EW score of 2 or higher. And then I need to tell the nurse, hey, are you aware you have an EWS alert? So anyway, that's basically what the EWS is. So this is how we decide what to do based on your score. So you add every score. It's quite self-explanatory, right? And we'll have another example slide. So 1 to 5, it's the low level. You basically need to manage what was causing their vital signs from escalating. Is it caused by fever? Is it caused by pain? Is it caused by anxiety? And then other than increased monitoring, the patient remains in their admission floor. So if it's a med-surg floor, they stay there. If it is oncology floor, they stay there. If it's the PCU, they stay there. They just increase your monitoring. If the score is higher, 6 to 7, then you need to actually call the physician, that is your house officer or your senior house officer or your on-call physician, to actually visually assess the patient. And then based on their assessment, they could give additional orders, and they could just increase the frequency of monitoring or order additional labs if they're not sure what's happening. Obviously, the next color is red, just like your triage. Red is pretty bad. So most of the time, aside from getting the doctor there, so look at the time difference. From orange, they have an hour to see the patient. If it is a red, they have to be there within 15 to 20 minutes. And obviously now with our system, we even added other things we could call. If the doctor is busy, we could just call a rapid response. So we have a team that are trained to just deal with it with standing orders without waiting for the doctor. And then we could actually upgrade the patient. So from med-surg, they could go up to PCU. If the patient is already in PCU or progressive care, we could upgrade them to ICU. So that's your red. And obviously, if it is a blue, that's essentially like your code blue. So we have a number to call. So in this hospital, it was 777. In our hospital, is 666. Weird number, right? So we call them, and then we need to upgrade the patient or intubate the patient on the spot. So let's do a patient example. So on the left side, we have the admission parameter. So we have a patient, 56-year-old, admitted to the med-surg floor with small bowel obstruction. So those are his vitals. And on the boxes, I already graded based on the EWS, what's the score. So for this patient, the score is only 2. So what do we do if it's only a 2? You continue monitoring, you address probably this patient is only in pain. So on the right side, 24 hours after admission, right? So just admitted to the med-surg floor because low number 2. Suddenly, the heart rate is the one that triggered it, right? You have AFib, which is a type of cardiac arrhythmia. So obviously, if your atria is not pumping, how's your cardiac output? It's going to be low. So that's causing the blood pressure to also drop. So from 0 score, it became a 1. And then obviously, probably with the pain and what he's feeling with his heart racing, his room sats is now 93, but still oriented. So long story short, what is our criteria? Technically, it would fall under MET, medical emergency for the 3, because that's a high score. But if you actually addressed it and the rapid response team came to the bedside, they would realize that we could treat this at the same site if you're allowed to give cardiac drugs on the med-surg floor, or we could actually upgrade the patient to telemetry. And that is what happened to this patient. So if we catch these subtle changes, we could avoid having to have a code in our hands. So that's based on the score. The patient was addressed based on the score. Another patient. So we have this time a 69-year-old admitted on the med-surg floor for a bladder infection, cystitis. So look, came in with a fever. So that's a 1. Obviously, you're febrile. So you're tachycardic. So that's another 1. They're probably in pain, right? With the infection, dysuria. So that got them a score of 2. Blood pressure is within normal. O2 sats, 96 on room air, and alert-oriented. So 69-year-old, alert-oriented. So total score of 4 could survive on the med-surg floor. 24 hours after, look at what's happening on the vital signs. Action is getting worse, considering that it's 24 hours, the antibiotic should have started working, right? So essentially, in summary, the patient is becoming septic. So what's the thing that would make us move this patient from med-surg to ICU? See how the patient is now confused? The patient is only alert-oriented times 1. So in the elderly, that's a threshold. They could become confused so bad. So with the scores, this patient was moved to the ICU for sepsis management. So this patient could have been left there in the past without EWS scoring, but with a criteria now with EWS, we have more definite decisions to create to minimize patient injury and damage. So hopefully that helps you understand EWS. So it is built in the program. It is a standardized scoring system using the 6 criteria. And based on the 6 criteria and your score, your patient could be upgraded to a higher level of care. So from med-surg to telemetry, telemetry to ICU. Or worst case scenario, you could get a code in your hands. So we are on number 5, patient safety goals. So another safety issue in the clinical area are infections, right? Your health-associated infections. A majority of this, that's why it's number 5 in the list, is common already, right? Especially with the recent COVID, we are doing a majority of this already. So obviously, the single most effective way of preventing infection, so we have stickers in all our alcohol gels and all our sinks. Wash your hands before and after patient contact. Second, if you are a nurse or if we have visitors, we have actually a secretary that screens visitors when COVID restrictions were lowered. You cannot come in the unit if you are sick. So if you are sick, they screen you already. If not, you can just call your family or video call them. Third, we never give antibiotics unless we know that it is something that requires an antibiotic. Because if not, you could build resistance. So very, very important that the physicians and the nurses follow up on culture results. So we will always start from broad spectrum, and then we do definitive antibiotic therapy after our cultures are resulted. So remember, that's part of the lab call, the critical results. You need to call the doctor immediately if the culture results are up so that they could change the antibiotic as needed. Next, we would follow our transmission-based precautions. So what are those posted signs? Is the patient on airborne precaution? Is my patient on droplet precaution? Is my patient on contact precaution? Or is my patient on neutropenic precaution or just standard precaution? So you need to follow and wear, so that's the next item, wear your correct PPE depending on the precaution you need to enter. So if it's airborne, right, has to be single patient room and 95 mask, right? If it is droplet, you could just wear your regular mask and wear eye shield if you're suctioning. If it is contact precaution, you need to wear your gown, your gloves. And if you are doing something that could cause splatter, then you need to wear your goggles and your mask. If it is neutropenic, then it has to be in a single patient room. No raw food, no plants or flowers, and obviously no sick caregivers if it's neutropenic precaution. Again, I know some nurses don't agree, but most of our hospitals, we mandated your vaccines to be up to date. So your flu shots and your COVID-19 vaccines and boosters, and obviously safe use of injectables. So 1 needle, 1 syringe, 1 patient, and then we have safety boxes to discard them, never recap, right? We've been taught that way back nursing school. Then obviously the COVID just emphasized how environmental cleanliness is important. And last but not the least, just like what I've been telling you, we don't just educate the nurses, we actually tell the patients themselves. Tell your nurse or, catch your nurse if you don't see them washing their hands. So our police is actually the patient. So we tell them to remind their nurses also and their practitioners, did you wash your hands before touching the patient, right? So So patient education. And obviously, it says there in the previous slides, 10. So how come there's only 9 boxes? The 10th box is actually, you need to know who your infectious control person is. It could be a physician or a nurse, where you need to be reporting things when they are not done correctly, or when you have to report someone that's not following the rules. So that's the number 10 step in keeping everybody safe. So what are the most common health-associated infections? So I only chose 4 because these are the most common projects that almost all hospitals follow. So we'll cover them one at a time. So the most common one is your catheter-associated urinary tract infections, otherwise known as COTI. So how do we prevent COTI? So these are the 7 steps. So this is very common in all hospitals. So I provided the slides for you because they're quite self-explanatory. Check if you need the catheter or not, because if you don't need it, don't put it in because it's a foreign body. Obviously, every time you insert a catheter, sterile technique, you need to make a documentation why you put the catheter in and how. 4, of course, we need to clean it every time, right? Maintain asepsis during the time that the catheter is in. You do not collect specimen and send it unless you have an indication for it. And then remove the catheter as soon as it is no longer needed. And obviously follow up if the patient is experiencing any signs of infection. Okay. And then we have, you need to report and document if you do have COTIs or your catheter-associated urinary tract infection. So that's why when I used to work on the med-surg floor, automatic, the day after surgery, we take out all catheters. Unless there's a medical reason, we need to keep it for another day. Okay. Next one in the ICU is we have our ventilator-associated pneumonias, right? Especially during COVID. This is very important, is to extubate patients as soon as we can. So this is universal, this is global. So what are the VAP bundle? So the VAP bundle, and this is true for all hospitals all over the world. When someone is intubated, you need to make sure their head of the bed is elevated at least 30 to 45 degrees to allow for lung expansion. It is required for the nurse to do oral care at least once a shift. So if we have a 12-hour shift, that's twice a day with chlorhexidine, which is an antiseptic. We provide stress ulcer prophylaxis. So you either have your PPIs, your proton pump inhibitors, or your H2 blocker. Because remember, when gastric acid regurgitates, it could aspirate to the lung. So we prevent that. Obviously, most important, we always check, do they need to be intubated still or could we extubate them? So we have daily sedation vacations and spontaneous breathing trials to see if we could extubate the patient. And 5th element of the VAP bundle is DVT prophylaxis. Not only are we preventing ARDS or pneumonia, but obviously we're also preventing deep vein thrombosis because the patient is immobile on the bed. So those are the 5 VAP bundles for ventilator-associated pneumonias that we could prevent. Next is your central line. So I'm not sure in Indonesia, but here in the United States, usually in the ICU or in the oncology unit, we usually have central lines. So we have PICC lines or central line catheters because we give so many drugs that we can't be having multiple IVs. So we call them your CLABSIs or your central line associated bloodstream infections. So you hear that a lot in clinical. So what are the things that is mandatory for all hospitals? So usually they build a team that actually monitors all the patients with the central line because nurses are already so busy. So usually we call it the line team, and the line team is usually the one that makes sure that the dressings are changed, that the Kuras caps are on. So obviously this is a basic poster that most hospitals use. So hand washing obviously before you touch the central line, make sure the dressing is intact. See that green cap at the end of the ports? That is what we call a Kuros cap. So the Kuros cap has an antiseptic solution in it when the line is not in use to prevent bacteria from growing. And then the lines, it takes time to change the dressing, right? So that's what the line team is for. So they want to make sure that all dressings are changed the day after they're put in because usually they become bloody. And then 7 case into it. And then as nurses, we are required to check on our line every shift. You know, we check if there's blood return, and then we flash it all the time. And of course, if the patient has the line for a long time, we want to make sure all our tubings, our bags are changed every 96 hours and as needed. And then when needed, there's signs of infection, then we need to send cultures. But if not, we don't draw routine cultures. And of course, remove it as soon as you can, the line. Once you don't need it, you're required to remove it with an order, obviously. And then we are required to do CHG bathing. So what is CHG? CHG is chlorhexidine. So it's like an antiseptic packet that is designed for full body bed bath to minimize microbials on the skin when your central line is present. So as ICU nurses, you are required to bathe your patient once a day with CHG, with the central line. So I'm a night shift nurse. I usually am the one who does the bathing at night because they're busy on the day. We're almost there. So we have surgical site infection as the next source of infection. So we have what we call SCIP, so SCIP. So surgical care improvement project. So what are the standardized, and by the way, this is international also and global. You know, if you talk to an OR nurse, they know what they're talking about. So what are these? So starting from the med-surg floor all the way to the OR, all the way to the post-anesthesia care, we make sure that the patients the day of or the night before has the heavy cleanse bath. So they shower using a specialty soap ordered by the surgeon. And then 30 minutes to an hour before cut time, depending on their surgery, they receive 1 prophylactic dose of antibiotic. Remember in the past, when I was a student nurse, we used to shave. We don't shave anymore because you could cause nicks and cuts. So they actually just clip hair when needed. And most of the time, it's actually the circulating nurse or sometimes is actually the one who does it. If they don't need it, they don't cut because that could cause minute openings. Then, of course, surgical hand washing, right? You practice that in the OR. And then, of course, correct prep of the skin. If they would use chlorhexidine or iodine or any other cleansing solution ordered by the surgeon. So these 5 components are mandatory. And this I got from the Global Alliance for Infection Control in Surgery. So this is followed worldwide and not only in the United States. So that summarizes patient goal number 5. So patient goal number 7 is to identify safety risks among patient population. So the Joint Commission identified suicidal patients as a high-risk population. So what did they institute in the hospitals? They required all patients to be assessed coming from the ED or in the community before getting admitted. So they want to identify if you have the risk factors to kill yourself. They want to identify if you have protective factors or the support system, if we could just discharge you to the community or your family or admit you. And then we need to do a tool, a complete assessment for suicidal thoughts, suicidal plans, or your intent. And depending on your answer and your suicidal score, you would either be admitted inpatient or you would even get a sitter. So that is what we call a sitter. There's actually another person watching you in the room 24/7 with your nurse as you're getting the treatment. And obviously, we need to document them every hour. What are they doing? We do our suicide precaution. We remove every material in the room that they could use to kill themselves. So that's patient goal number 6, which is directed towards mental health, suicidal patient. Last but not the least is related to patient safety goal about surgery also. So remember, we go full circle. Isn't it patient goal number 1, wrong patient? So obviously, another area where this happens a lot is in the OR. So wrong patient, wrong site, wrong procedure, especially if your surgery is on bilateral parts of the body. So right arm versus left arm, right leg versus left leg. So anything that's right and left, we need to actually, 1, talk to the patient and in their own words tell you what surgery they're getting before anesthesia is administered. Number 2, the surgeon actually has to mark the site with a marker. or they would put yes on the surgical side. And then number 3, when anesthesia is already induced, there's the scrub nurse or the circulating nurse would actually call for a timeout, or the surgeon himself. Okay, we're gonna do a pause. Who is this patient again? What are we doing? And where are we doing it? And that is documented. So that is what we call the surgical pause or surgical timeout. And that summarizes our 7 patient safety goal. And last but not the least, for objective number 3, what if something happened and you need to write an incident report? So obviously something happened, patient fell, patient received a wrong drug, etc. Your priority action is to check the patient first. So you need to do a full assessment, give emergency intervention if needed, then notify the physician, get additional orders depending on what happened. You know, if you need extra x-ray, ultrasound, or you need to get an order for an antidote. And then, of course, once the patient is safe and stable, notify the patient and family. You need to tell them honestly, you know, something happened to you. We are sorry. And this is what we did. Because honesty is the best policy. And obviously, you need to write a separate incident report. So it's not part of your chart. It's an incident report, part of our hospital system, for us to investigate what can we have done different to prevent this same incident from happening. And that's the end of our discussion today. Hopefully you guys learned something. Do you have any questions? And I sent a copy of my slides with the references to Dr. Wiwin Martin-C. So if you need a copy, you could get it.
Thank you very much, Ms. Carmela De Leon, for giving us such informative and interesting presentations. Ladies and gentlemen, now come to the questions and answer sessions. I would like to have some questions from the participant, please. You can write the questions in room chat Zoom or directly ask to Dr. Carmela by opening the camera and mic. Anyone, please? Yeah, from 1A, Putri F. Azahra, you can open your mic to ask Dr. Carmela directly.
My name is Putri Fadila Azara from grade 1A. First of all, my apologies that I can't turn on my camera right now due to my bad internet, ma'am. So the question is, may you explain the reasons why after washing hands before surgery, the hands position should be stay in line with shoulder?
Can you repeat your question?
Slow. Hello, Miss Putri.
Yes.
Very fast.
Yeah.
You're asking why after surgical hand washing, you need to put your hands like this?
Yes, ma'am.
Oh, okay. That's a good question. So if I remember right from nursing school, anything above the waist is considered safe. Anything below the waist or table level is considered unsterile. So you never put your hands down. You should always put your hands where you could see it. And the marker, you know, I don't know why they made it that way, is our waist or the table level. So if you had your surgical scrub table, you know, the half moon in the OR, you never put your hands below that. So if you're dropping something to the trash can, you just drop it from waist level. You never put your hand close to the trash can. So that's the rule. So you could see it if you accidentally touch something. So always waist level and higher.
Okay, ma'am. Thanks for the explanation.
Okay. Any other question?
Anyone, please? Another questions? You can write the questions in room chat Zoom or directly ask to Dr. Carmela by opening the camera and mic. Ma'am, there's questions in room chat Zoom. I can read it for you. Am I audible?
Yes, I could hear you.
Yeah. The question's from Kisatul Latifah. The question is, apart from leaving a small gap to see the blood on the label, is there any other reason for that?
The main reason where you have to have a gap with the sticker and you can't wrap it around because the people in the lab, when they put the tube in the centrifuge, the one that spins the blood, you should be able to see if the blood is coagulating. So they actually need to have a space to see that. So they don't need to lift the whole tube. They could just lift it up. There's a space instead of getting the whole tube out. That's what the lab people told us, why they have to have a space. Hopefully that answers your question.
Thank you so much for the explanations. Okay, next questions. Anyone, please?
Maybe I want to ask, just want to something. Moderator, may I can ask something? So, voice. Suara saya terdengar? Kok di sini nggak mendengar
Yes,
apa-apa?
ma'am.
Oh,
Elona.
Ya, terdengar.
Yeah, you forgot to unmute your mic.
takutnya komputernya ini error. Yes, Ma'am Carmela. I just want to know about the practice of EWS in your hospital.
Yes, ma'am.
Maybe every unit use this score.
Yes.
In your hospital, every unit and every hospital in your place, like this?
I could only answer for the Banner Health System, and that's about 30 hospitals in Arizona. And then other hospitals in the US, they have a form of the EWS. Not all, because sometimes they already have the rapid response and the set protocol, but usually it's the med-surg and telemetry. ICU, we don't have anymore because that's the highest level. So it's the lower level units that has the EWS because that tells us if we need to upgrade them to a higher level of care. So all med-surg units and all telemetry units has it until they get to ICU. ICU, no more.
And when we use this score, maybe every morning, every evening, or one day and one time just to use it? Yes?
24/7, ma'am.
Oh.
Continuous because it's the computer. Once you enter vital signs, for example, on the med-surg floor, they check vitals every 8 hours.
Oh, okay.
They check vital signs, and ICU telemetry checks every 4. So that's 3 times in a shift. In the ICU, we check every hour. So we don't need it because we're checking every hour. So every time your CNA, your your assistant enters the vitals, the computer thinks about it and processes it. And then if they meet a criteria score, they send the nurse a message. It would appear on your charting. You have a task, like a new order that you need to check on the patient. And then depending on the score, your vital signs could be every 2 hours instead of every 4 or every 1 hour, depending on the score.
Itu ada pertanyaan yang lain, Mbak Ilnuna. Maybe
Yeah, there's
another student, yes.
another questions in room chat Zoom. Come from Farhan Martiza. What things affect communications between nurses and patients?
One would be language barriers, because we have patients coming from different countries. So obviously that would affect communication. So in most hospitals, we have what we call your Cyracom. So it's a phone. So it's a two-way phone where the patient holds one, the nurse holds one, and then we have an interpreter in between, translating the patient's native language to English, and the nurse or doctor's answer to the patient's native language. If we have a deaf patient and mute who signs, we actually have a video conference so that they could sign so we understand. So every time you talk to the patient, you have to use the phone or the video translator, or in the daytime, they actually have a live translator available. So the main communication for patient safety for us here in Arizona is the language barrier.
Yes, ma'am. Thank you for the explanation.
You're welcome.
Okay, thank you for the answer. And the next questions come from Ines Aziza.
Maybe I want to ask for Miss Carmela from Pak Agus.
Yeah, go on, sir.
Okay, thank you, Miss Carmela, about your explanation. This is the seriously exactly about patient safety. As a teacher, maybe we have the hard responsibility to prepare our student before attach or practice in the hospital, exactly to prevent accident. Because in fact, to prevent accident, exactly on patient safety, need discipline seriously, good collaboration, and exactly with other profession. And then maybe you can give me tips here to improve our nurse student on management patient safety before practice in the hospital. In this forum, maybe there are many laborant, Miss Irka, maybe how to prepare laboratory exactly to give a good experience to our student in patient safety. I think that's our question, Miss Carmela. Thank you.
Yes, sir. Thank you for the question. So for us in the school, for our freshmen who don't go to clinical yet, we have check-offs. So they have to pass certain check-offs before they could go to clinical. So for example, we have check-off on hand washing. So that's their first check-off. From the very first week in nursing school, they check off on hand washing. Then the week after, they have a check off on PPE, donning and doffing. And then we go from there. So the next check off would be oral meds. The third check off would be sub-Q and then IM. And then on the next level, they'll have to do a scenario of talking to a patient from admission. So we have many scenarios on communication. And then their next check-off in the next year would be IV pushes, blood transfusion. So every year, there are certain check-offs for every semester before they go to clinical. That way they could practice on the mannequin or they could do role-playing. And then we have a list that they need to meet. If they don't meet it, then they fail. Then they have to do it again. Just like your lab, I saw in the video that you have a very beautiful simulation lab. So we actually use the simulation lab for that purpose. So we make them go in, talk to the mannequin, and then there's a faculty speaking as the mannequin. Remember, we have speakers. and they would answer like they were the patient.
Okay, maybe one question again. When our children make mistake in the hospital, exactly when take a practice in the hospital, attachment in the hospital, and then based on your experiences, Ms. Carmela, maybe how to solve this problem if our children make mistake in the hospital, for example, wrong give drug, rude dose, and etc. Okay,
So
thanks.
for good question, sir. So what do we do when that happens? So number one, if it's their first time doing it, they always have to do it with the instructor. And then if they made a mistake without the instructor, we tell our students not to be afraid, but to report. They have to report. Once they report, then we have a booklet of steps to remediate. So usually they'll go back to the school. They either have to watch a video or research an article about whatever safety issue they committed. Then they also, depending on how severe issue they created, they have to report to their classmates, make a presentation in their class about what happened, what did they learn from research as part of it. And then depending on the issue they created in clinical, sometimes we need to make them report to the Board of Nursing. And then they have to attend the hearings in the Board of Nursing, so they learn that they're not alone. Other people also committed some errors, but they learn that they need to be honest to report it. Then they have to do remediation and extra hours. Once they fulfill the extra hours and all those things that are listed in the manual, then that's the only time they could go back to clinical. And then the instructor watches them more closely until they graduate.
Okay, thanks. So, oke, Mbak Linola, dilanjut.
Many questions in the chat room. Maybe moderator can.
From Ines Askiza, how to make a good conversations about medical between outpatients?
With our elderly. So normally for the elderly, we always make sure that their hearing aids are on, or if they require visual aids, that they're wearing it before we talk to them. When we make posters for teaching or pamphlets, we could print them out bigger. Because remember, the older they are, it's harder for them to see. And then when we do teachings for them, we keep it short. Because remember, the elderly, their attention span, like kids, are shorter. And then we want to make sure that family member, their caregiver is present when we do teachings, remember everything. And it is mandatory in all states and all hospitals that when you give health teachings, you print it. You have to have a printout of what you taught them, like pamphlets. And for us, we don't need to make the pamphlets. It's online. It's built in our charting. So if you thought about, for example, X medication, when you print out their discharge papers, you click the box for what you taught, and it's actually going to be printed out on a patient teaching sheet. That way, when they go home, they could come back and reread the instructions, because we teach so much, right? For the elderly or any patient for that matter, we do the same thing. Hopefully that answers the question.
Thank you, ma'am. Okay, Ms. Erika Maharani, you may deliver your questions to Dr. Carmela.
Yes, thank you, Elnona, as the moderator. Good evening, Ma'am Carmela. Yes. Ma'am, so I'm going to tell a story actually. So when it's around 5 years ago, 5 or 7 years ago, I went to Surabaya by train, and in the middle of my way, when I stopped at Malang stations, there is a woman sitting in front of me, and she talked too much with us, with people around us. And then after that, we confused what she was talking about. And then finally I noticed there is a patient wristband on her. Oh my God. So yes. And then I tried to check the patient wristband, and so she's coming from the hospital in Malang. And then I tried to call my friend who worked in that hospital. And so as my conclusions, she got a mental illness at that time. So what do you think about this case? Because this is also related to the patient safety, especially for the patients with mental illness. Thank you so much, Ma'am Carmela.
Yeah, wow, that's a very unique story. I'm glad you guys found her and sent her back to the hospital. So normally in our hospitals, was she wearing a patient gown aside from her armband?
Sorry?
Was she wearing a patient gown?
No.
Regular
Yes, the regular dresses, costume.
So normally, like I said, in our hospital, when they are mentally ill patients or suicidal, they have a sitter. They actually have one-on-one sitter that sits with them. Number two, our mental health facilities here are lockdown facilities. So there's only one gate in, one gate out. So they would have figured out if someone, absconded or left. Some hospitals, there's a chip on their armband that when the patient exits the door, their alarms go off. So those are just some examples of the hospitals here. But then again, we have smaller hospitals in the community who doesn't have that. So normally what we do is, when I was a public health nurse in the Philippines, and technology then was not yet that good, we would always connect with the community. We have community health workers that knows the people in their community. So that person would have been identified by the people in their community, and they would have easily recognized that they should not be out. So that's how community helps. And obviously the police here in the States. But in general, if technology is not available, like the alarm system when they cross the door, then at least the community people, we tell them, because normally in psych wards, they have to have a visual assessment every 4 hours. So if someone was missing, they would have found out. Right. I'm glad you even saw the armband.
Yes,
right?
ma'am. Fine. Yes. Thank you
Yeah.
so much for the explanations.
Yeah, you're welcome.
Okay, Mr. Andi Hayun.
Thank you. Hello, Dr. Camela. Good evening.
Hi, sir. Good evening.
Yes,
Good
a
morning.
very wonderful explanation about the management patient safety. Yes, I have one question. What kind of indicators that management patient safety can be, say, successful, even in hospital? Yes,
Sir, can you
thank
repeat
you.
the question? You got cut
Yes.
off there.
Is there any indicators that management patient safety can be successful in the hospital? What kind of indicators?
Yes.
Okay, thank you.
Yes, sir. So usually in the hospital, because we already have electronic charting, we could already track our outcomes. So for example, during 1 month, if no COTI occurs, so that's good. If no falls occurred, that's good. If there's no CLABSI that occurred, then that's good. So for us, it's 24/7 monitoring. It's easy for our nurse managers or our infection control people to see, because we're already electronic charting. So once you chart, or they found out there's no infection, there's no fall, there's no pressure ulcer, or if there was no incident report, because we are required to do an incident report for every fall, for every CLABSI, for every code, we need to put a report. So automatic, when those reports come in, we already could calculate our score our report card. So obviously the goal for every hospital is to have 0 occurrence. So obviously we have thresholds. You know, if you're a very busy ICU, sometimes you could have a threshold of 1 per month. If you go less than 1, then you're awesome. Then they'll give us a pizza party or they'll give us coffee party, you know, a coffee cart would come through the unit. So they give us prices just as a good reminder that, okay, you guys are doing what you're supposed to do. So we could monitor with our electronic charting. From the backside, they could already see how many incidences we get in a month.
Okay, thank you, Dr. Camilla.
Okay, I think that's the end of the question and answer sessions. Well, ladies and gentlemen, we finally come to the end of these occasions. Before I close the event, I would like to take the conclusions from what the speaker has presented. Be mindful to our practice as health workers, mindful practice to prevent, protect, and preserve. Seeing the patient's identity is very important to improve the quality of patient safety. That's why technology is very helpful in improving patient safety so that the patient does not suffer loss. Learning EWS will help improve our skills to identify patient needs. I would like to thank the speaker for the informative and interesting presentations and all the participants for the very active participations. Thus the material presented by Ms. Carmela. Hopefully it will be useful for all of us. And as the moderator, I apologize if there are mistakes. I return it to the MC. Thank you. Wassalamualaikum warahmatullahi wabarakatuh. Thank you, Dr. Carmela.
Thank you. Tidak ada penutupan lagi.
Okay, thank you. I say thank you very much for sharing with us Ms. Carmela Teresia de Leon, PhD RNBC CCRN, as the speaker today. It was an extraordinary material, and I also thank you very much to our moderator, Elnona Humayma. Okay, ladies and gentlemen, the next agenda is closing statement by Head of Data Nursing Diploma Field Study Program, Mrs. Dr. Sri Bugianti, as Nurse MCAP. Time is yours.
Ya. Makasih, Rita Ayun. Ya. First and foremost, I would like to express my appreciation to the speaker and for your valuable contribution to our guest lecture today. Yeah, my deepest gratitude goes to all who attended the webinar and helped to make it such a successful event. Yeah. And Carmela, hopeful one day they can meet in the future and work together on other activities. As a sign of appreciation from us, the committee will immediately send a certificate to Ma'am Carmela.
Salamat datang, ma'am.
Ya, ya kami hanya bisa memberikan sertifikat, Ma'am Carmela. Ya. I also want to say thank you very much for the cooperation of the committee to make this event a success. Hopeful it can be a part of your learning process for all of you in the future. Yeah. See you. Thank you. Saya kembalikan ke moderator.
Thank you very much for the closing statement to Mrs. Dr. Sri Mugianti as Nurse MCAP. Okay, ladies and gentlemen, the next agenda is praying to Muhammad Hirman Fernando. Time is yours.
Assalamualaikum warahmatullahi wabarakatuh. Salam sejahtera bagi kita semua. Salam, Om Swastiastu, Namo Buddhaya, salam kebajikan. From Muslim, I will read the prayer. From non-Muslim, please adjust. A'udzubillahi minasyaitonirrajim. Bismillahirrahmanirrahim. Allahumma sholli ala sayyidina Muhammad wa ala ali sayyidina Muhammad. Walhamdulillahirabbil alamin. Ya Allah yang Tuhan kami, pada hari ini kami melaksanakan kegiatan kuliah tamu dengan tema Mindful Practice Patient Safety Management and EWS Practice. Berilah kami petunjuk, taufik dan hidayah-Mu, sehingga kegiatan yang telah kami laksanakan ini dapat membawa barokah bagi kami. Ya Allah yang Maha Pengasih dan Penyayang, karuniakan kesadaran, ketabahan, serta keikhlasan dalam menjalankan tugas mulia ini. Ya Allah yang Maha Berkehendak, perlihatkan kebenaran di mata kami. Bukakanlah jalan yang lurus menuju surga-Mu. Berikanlah kemudahan dan kelancaran dalam setiap langkah kami. Ingatkanlah kami, agar kami senantiasa meneladani perjuangan para pendahulu kami, para pahlawan kami, dan pemimpin kami yang telah memberikan dharma baktinya bagi kami di masa yang akan datang. Ya Allah yang Maha Pengampun, ampunilah dosa kami, dosa kedua orang tua kami, serta dosa pemimpin-pemimpin kami. Berikanlah petunjuk dan kesadaran agar senantiasa melangkah di jalan yang Engkau ridhoi. Bimbinglah kami kepada jalan yang benar, serta jauhkanlah kami dari segenap petaka, khilaf dan derita. Rabbana dzalamna anfusana wa illam taghfir lana wa tarhamna lanakunanna minal khasirin. Rabbana atina fid dunya hasanah wa fil akhirati hasanah wa qina adzabannar. Allahumma fiq la wa mitarik. Wassalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh. Well, that's wrap up our event today. Again, the announcement for the participants. The evaluation form is available in room chat, Zoom, and YouTube. So for the participant, please fill the form. The announcement for the participants. The evaluation form is available in room chat, Zoom, and YouTube. So for the participants, please fill the form. Okay, ladies and gentlemen, before we finish our activity today, there will be a documentation session by documentation team. I please for all the participants to turn on the camera. Okay, I please for all the participants to turn on the camera. Okay, so documentation team, time is yours. Okay, I will lead for the session. I'll start from the slide 1 and I want to count down in 3, 2, 1. Okay, next to slide 2 in 3, 2, 1. Okay, next slide 3, 3, 2, 1. Next to slide 4 in 3, 2, 1. Slide 5, 3, 2, 1. And the last slide in 3, 2, 1. Okay, thank you for the documentation team. For the announcement, this program has a benefit to get a certificate. So for the participants who want to get a certificate must complete the attendance and evaluation form. For the announcement, this program has a benefit to get a certificate. So for the participant who want to get a certificate must complete the attendance and evaluation form. Okay, ladies and gentlemen, finally we've through all our event today. So I, as a Mrs. of Ceremony today, personally, I would like to say I'm so sorry if there are mistakes in my utterance during handling our program as on session this program. And I also say thank you very much for your participation in this program. Now, let's we close this activity with recite Alhamdulillah together. Alhamdulillahirabbil alamin. Okay, ladies and gentlemen, now all the program has been ended. So I, as Mrs. of Ceremony today, I do apologize for any mistake. See you and wassalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh.
Wiwi,
Thank you,
ada
Dr.
Kak Kisah.
Carmela.
Kak Kisah.
Thank you, Dr. Carmela.
See you soon. Bye-bye.
Sukses, Bu. Makasih. Sukses.
Ya, makasih Pak Kisah.
Makasih Pak Kisah.
Makasih,
Dek.
Bin. Makasih.
Ya.
Sukses.
Semua sukses.
Panitia, terima
Ya,
kasih
panitia.
semuanya.
Ya. Ini live YouTube-nya dicopot dulu tuh.
Ya. YouTube-nya di
off-kan dulu.
Pas dulu. Off dulu.
Izin saya end meeting ya, Bu.
Anu panitia untuk sertifikat tadi masih dalam bahasa Indonesia, please change in English. Yes, jadi tadi tulisannya masih pemateri gitu.
Ya nanti dikirim ulang.
Ya, jadi jangan dikirim ke Carmela dulu kalau belum diubah. Sudah tutup, izin meninggalkan ini Zoom.
Terima kasih banyak.
Terima kasih semua panitia, Pak Agus.
Selamat semuanya, terima kasih.